All righty. So we're talking about a twist technique to explant a lens. You know, sometimes there is a need to take out our old IOL and replace it with a new lens. And there are many ways that have been described to do this. The traditional way is this, cutting an IOL inside the eye. And this works well, but it does require specialized instrumentation, such as these micro scissors and micro graspers. I know Ike was instrumental in getting this set out to the world, these MST style instruments. And once the IOL is cut in half or mostly in half, you can then pull out one half and then the other half will follow. And so this certainly works, but it requires, again, specialized instruments and it takes a little bit more effort. Also, you don't have the ability to have an intact IOL at the end. Once we get the IOL out of the eye, of course, the IOL has been damaged or cut in half, etc. So there has to be a better way. This is a technique that I learned from Jack Chapman in Georgia. I'm going to show you this. When I first saw him do this, I was blown away. It's to twist the lens within the eye. So all you need is a spatula and straight tying forceps. So there's the IOL on top of the iris. You grab the optic, not in the center, but at the edge. Grab the edge of the optic. And this video is a resident who is doing the entire case. Now the spatula goes on top. The spatula helps to roll the IOL. And so now we twist the tying forceps, trying to do a full 360 twist. Start with your hand either pronated and supinate or do the opposite. And then once it's rolled about 360 or as much as you can, just pull it right out of the eye. And so now you can explant that single piece acrylic lens through a 2.75 millimeter incision. Here's that same case outside the eye view. So you can see twisting it and it just comes right out the incision. So it works very well. Again, spatula is important to hold the lens and help roll it, plus protect the corneal endothelium. Anterior chamber is filled with viscoelastic. Once we get the lens twisted, again, we pull it right out of the eye. So it's a very useful technique that I think in your surgeries, you'll find to be a benefit. Here's now with a curved tying forceps. You see it's a little bit more awkward because the forceps aren't straight. The tips are straight, but there's a bend in the shaft. But still, even this video from a resident many years ago, you can see we can still pull the lens right out of the eye. Now the lens is intact and we can measure it or examine it or whatever else you need to do for that. And so here we go. One last time, remember, grab the optic, not in the center, grab it in the periphery, the edge. One haptic's already outside the eye. Spatula going on top. We're gonna slowly twist the forceps. And again, to get the full range, go in, for me, supinate, and then go in and pronate. And you'll get almost 360 degrees, which is enough. Now we can roll it up. We've tried this with the Alcon Acrosoft lenses. AMO Technis lenses have worked well. We've even explanted a 3-piece acrylic lens with no issue at all. If you have a silicone lens, keep in mind the silicone lens is very slippery, and that's a much tougher one. So we recommend this technique for acrylic IOLs of 1-piece and 3-piece varieties. And again, you wanna take the lens out, put it on the cornea afterwards, just to make sure you haven't broken off a bit of the lens, the haptic, etc. So in that case, after we explanted that one lens, I'm just gonna show you for the new lens, this patient is getting a 3-piece lens. As that lens goes, is gonna be placed in the sulcus. It's first placed on top of the iris, and then it can be dialed into position. So if you have a patient with a need for an explanting of an IOL, I encourage you to try this technique. You'll be quite impressed that it works so well. And then Arup, we're ready for any questions, and then others we can move to the second talk.
I think we'll just take up some questions. Madhu, you had any questions to be posed to Dr. Uday? Any comments to make?
Yes, sir. Very nice presentation, sir. I have a few questions that what is the exact position where we have to hold the IOL, and whether you have enlarged the incision and how much you have enlarged.
So I think a 2.75 incision will work fine. You don't have to enlarge more than that. If you did Phaco through a small 2 millimeter, 2.2 incision, you probably should enlarge it to 2.75, 2.8. You want to grab at the edge of the optic, right where a haptic is. So you saw in the video here, we pull one haptic outside the eye and then grabbing the optic at the edge. That allows us to roll it up. And Madhu, I used to do left-handed as well, but when I was a kid, my parents made me switch to right. So now when I do Phaco, I can do it either way, it doesn't matter.
Yes, sir. And one more question, sir. Any effect on endothelial cell count in this technique?
So we only had one patient where we did an endothelial cell count before and after, and we found no appreciable difference. It was within 1% or 2. So we're very careful to stay away from the cornea. That's the purpose of the spatula. Plus, you're doing this under the protection of viscoelastic.
Thank you, sir.
So I have a question for Uday. See, is it advisable to convert the rectangular incision into a trapezoid? You know, the internal lip is longer than the external lip of the incision, so that it is easy for you to capture the lens within the tunnel without traumatizing the tunnel too much before you pull it out.
I think that's reasonable. You can try that. In most of these videos, the residents are using a 275 incision to begin with. And so we just open the existing incision, Phaco incision. If you have a clear corneal incision that's totally avascular, you'll find that you can open it even a year later. If the original incision has hit the limbal vessels, then it may be requiring an additional cut. But the trapezoidal can be done, but I don't do it. You don't need to for this.
So when you rotate the lens, is there any possibility of damage to the underlying iris tissue, particularly if it is a very friable iris and it's a constricted pupil? Is it possible?
I'm sure that it depends on the case, but I'm sure that's a possibility. But again, we've probably done about 8 or 10 of these and had no issues.
Any questions from any of the speakers, panelists?
Hey, Uday, this is Tom Odding. Are you turning, which way are you turning it? You're turning it towards your second instrument or towards the iris?
So honestly, it doesn't make too much of a difference, but we're holding the IOL and we're turning it so that the natural tendency of the optic is to go up against your spatula. I don't want to push it down into the iris.
That makes sense. Yeah, I think it's really slick. Have you tried there was a technique that Bonnie Henderson published where you just pulled on the SNWFs to the wound and then you went across with a hook and just sort of buckled it to get it to start? And I tried that a few times and found it difficult. I think this is really slick. And the other thing is cool.
Yeah, go ahead.
I said the other thing that's really cool is sometimes you don't have Ike's instruments in that OR, or they're not ready, or one of your colleagues has already used them all up for the day. And so I think this is really slick, and I appreciate it.
Cool, thank you.
Sayan, you wanted something to say? Sayan, did you have something to say?
You have to unmute yourself, my friend.
You have to unmute, sir.
Yeah, Sayan, you're muted.
Sorry for that. Am I audible now?
Yes.
Yeah,
you're good.
Yes. So what should be the status of the pupil when the IOL is coming out? Would you like to dilate the patient pre-operatively?
Doesn't matter.
Doesn't matter. Okay.
No.
Yeah, I think only matters the. Yeah, I'm just saying that there could be an issue if you have a large rend, and the chance of vitreous prolapse would be higher if you had a large pupil. That probably is the only thing you'll have to think of. But I agree with Tom. It was a beautiful technique, and we're looking forward to trying it.
Exactly. So,
Arup, let's move forward. I want to keep you on track.
Thank you. So we'll go to the next case.
So this is a very fun one for me. This is, again, I'm with my residents at a free teaching hospital. We call a county hospital in the US. So the patients are getting free surgery and the resident does it. But we don't have a lot of fancy instruments. There is no excimer laser at the teaching hospital. We don't have the micro forceps that Ike loves to use. We don't have all these toys. So we gotta learn to be creative. Sometimes we don't even have a toric lens for some of the patients. So what we're doing is paired phaco incisions to treat astigmatism. And this is not a new idea. The pro is it's easy. There's no other instruments, fast, efficient, low cost. The cons, it's only about a diopter of astigmatism. And there are 2 potential leak sites because you have 2 incisions, and there can be a variable response depending on how you make the incision, and also the patient's age and the corneal position, all these things, of course, have an effect. So there's a 20-year history of paired phaco incisions. And you see in the past, these were all greater than 3 millimeters, and they caused 1 to 2 diopters of flattening. Remember, a superior incision that's identical will have more astigmatic flattening than a temporal incision. And this is an important thing to remember. So here, standard phaco incision, sitting temporally or superior, whatever your preference is, finish the case. Now with the eye full of viscoelastic, and the IOL is protecting the bag, a little more viscoelastic in fact. Now with this eye full of viscoelastic, we're gonna make an opposite phaco incision, full thickness, the same tunnel length, the same design incision on the opposite side. And so when you make this incision, now you have more flattening. Against the rule, maybe you'll get about a half diopter flattening with 1 incision. But if I have 2 incisions, I can almost double that. I can get up to a diopter of flattening. So depending on where the effect is, the position is, you'll change the effect. So here now is a sitting superiorly one. So we're sitting superiorly, doing the phaco incision, and that looks like a pretty nice incision. End of the case, IOL's in the bag, more viscoelastic going in the eye. And now we're gonna make an opposite incision. So this is operating at about the 90-degree meridian. So this is for with the rule astigmatism in this patient. And so we make the same incision, opposite side. You can go all the way in like this, or you can go partially in to titrate the effect. If I just have the 1 phaco incision superiorly, it's probably a half diopter or so of corneal flattening, maybe a little bit more. But if I have a paired incision now, I can get a solid diopter, maybe even a little bit more of astigmatic treatment just from the phaco incisions. So you can also shift your hand to access different meridians. Like I was saying to Madhu, I can do left hand or right hand. So here is right-handed, and we're operating at about the 75-degree meridian. The ink mark there is 90 degrees. At the end of the case, we switch hands. This is now my left hand and doing the opposite incision. If you're a young ophthalmologist in training, I encourage you, use both hands. You should be eating food and brushing your teeth and doing things with your left hand to improve that dexterity. Shave your face, do whatever you do, use both hands. Here's the end of the case. Make sure both incisions seal well. Now we can also do it in a private surgery center. This is using a diamond keratome in a private surgery center. So there's the main incision temporally at about the 15-degree mark. And then here at the end of the case is another one. So it doesn't just have to be the steel blades. You can use diamond. Here's the effect we found. We found that for a paired against the rule incision, we had about 0.7 diopters on average of flattening. And for with the rule, we had about a diopter's worth. So you can see there's quite an improvement there. There is a bit of variable range, as you can see from those error bars, but this tends to be a pretty useful technique, especially if you're young and in your training. And this will even work if you have to put a sulcus lens in, or you do a 3-piece lens, you don't have a toric lens, your capsule bag broke, you did an antivitrectomy, it's all okay. Do this at the end of the case, again, when the IOL is already in the bag and the anterior chamber is filled with viscoelastic. Remember, a wider incision will have more effect than a narrower incision. So 2.8 will have more effect. A more central incision within the clear cornea will have more of an effect than if you're at the limbal vessels. A shorter tunnel length, again, more effect, and the incision may not seat as well. Whereas a longer tunnel length will have a little bit less effect, but it will seal better. If you have more than a diopter of astigmatism, of course, use a toric lens. That makes the most sense. It's the most accurate. This is not as accurate as a toric lens, but there's a big advantage. This is easy, and it's free, and requires no extra instrumentation. So again, starting your case with the phaco incision on the steep axis, fast forward to the end, IOL's in the bag, and there's the opposite incision, still on that same axis on the 180 degrees away. And you can do full thickness here. You can go a little shy of full thickness if you need to. Here's a good example. There's a before and after. 1 1/4 of astigmatism with the rule. Afterwards, 1/4 of astigmatism. And look at the refractive error from minus 850 going to plano and just a minus 1/4 of SIL. Beautiful result for this patient. And this is using just those full thickness incisions. So again, bottom line to remember, for 2.8 incisions against the rules about 0.7 of flattening, with the rules about a diopter flattening. And I think this is something that any surgeon, no matter what your level of training, you can incorporate this into your practice. Thank you, Arup.
A wonderful presentation, Uday. And anybody would like to add something or ask questions to Uday about the technique you just described? Uday, out of 10 patients with astigmatism up to less than 1 diopter, how many of these cases you employ limbal relaxing incision or the paired clear corneal, opposite clear corneal incision, for the numbers?
So I tend to, in my own practice, I'd rather do a limbal relaxed incision using a diamond, appropriate depth, and measure the pachymetry ahead of time. I think I'm more accurate with that. But when we're at our free teaching hospital, we don't have diamond blades. We don't have a way of doing an LRI other than the disposable LRI blades. And we find that this is probably easier for the residents and a little bit more forgiving. So in my private practice, I rarely use this technique, but with the residents, we use it every week.
What is the predictability and the consistency of the outcomes? I mean, because Warren Hill, let's say, they have taught us, the surgical induced astigmatism actually is all over the place. Very difficult to predict the magnitude as well as the meridian. And now the
key there, you can't exactly, you're going to change the magnitude in the meridian if you're using a toric lens and you're placing your incision off axis. So this is one of the benefits here. It's super forgiving. You're operating on the steep axis. And even if you're 5 or 10 degrees away, you still have an appreciable benefit for it. Look, if you have a diopter or more of astigmatism, you're better off with a toric lens. If you have less and you have a need, this is a very useful technique. There is a variable curve we talked about in the video. Position of the incision, the width of incision, the tunnel length of the incision, the patient's age, corneal white to white, all these things will affect it, of course. But try this in your own hands. I bet you'll be surprised. And it's not a new idea. This has been published 20, 30 years ago.
Exactly. Yeah.